we have a really special presentation to you guys today. As far as I am aware, this is the first ever comparative effectiveness study in Lennox-Gastaut Syndrome. I mean, I hope I'm not wrong about that, and there's more, but as far as I know, this is the first one. And Dr. Sandi Lam, who works at Lurie Children's Hospital, has really led the effort and worked with a great team to lead the effort on this, where they're comparing two things: surgery in our children with LGS versus the next medicine, right? So you have LGS, you've failed some treatments, you're up for one or the other, and which one would work best? And comparative effectiveness is so important because we don't know what works better in LGS. So I'm gonna bring up Dr. Lam. Please come up and thank you. And tell us all about this research study that you're doing on comparative effectiveness, seizures versus medication in LGS. There you go. And let me grab my hearing aids. You don't need those.
Thank you, Tracy, and thank you, everybody, for this is amazing. Thank you. This is just amazing to be able to spend time with the LGS community to really talk about something that is really super exciting, and really for me I'm a pediatric neurosurgeon. For me to learn from all of you, so I'm going to talk about this. Our research project. This is from the PCORI, which is the Patient-Centered Outcomes Research Institute. You'll see the research team. It's actually made up of multiple people, many more than this, but the core team is myself. I'm a pediatric neurosurgeon. Anup Patel, pediatric epileptologist that you know well. He was the medical director for the LGS Foundation. He's currently on vacation with his family, but he says hi. Mark Rosenman, who's a pediatrician, who's also a medical informaticist, and then Tracy Dixon-Salazar in representation with the whole LGS Foundation. And the premise of PCORI as a research institute and a funding agency is that those closest to the problem are really closest to the solution. So really all of you are part of this solution. So the research is not being done to you or for you. It's really actually trying to engage everybody to try to help us do better. So in this project, there are some very specific things that PCORI wanted help with, which is that the Patient-Centered Outcomes Research Institute actually has a national database. So they collect all this data, but they actually are not very good at figuring out how to use this data to learn about rare diseases. And in the number of patients that LGS affects, this is classified as a rare disease. And really, PCORNet data or national data sets were really much better for things like diabetes or heart disease. So really trying to focus on learning about epilepsies, and then really working with patients and families directly to study outcomes that matter to most to you. So as a background, I'll recap a little bit of what Dr. Suki Ko talked about in terms of the learnings from the natural history study. And also you'll see this QR code come up a few times in this talk. So feel free to grab a shot of it, and I'll tell you where else to be able to find it over time. And eventually I'll also be in the LGS Foundation website. But this is really a survey for all of you to help us learn more in this study, and I'll explain why. So the project is really talking about comparative effectiveness of medical therapy versus surgical therapy for LGS. And this is addressing it on a national level, how these decisions are made and how these decisions impact patients and families. So as Dr. Ko presented, and as we've learned about in these past 2 days, and as you live it every day, is that seizures are relentless, right? No matter what we do, what medications we try, we know we don't have a cure. And seizures can happen all the time. And when we look at how this affects every day, it's emergencies, right? It's crises. And when we looked at the natural history study, families reported that within the past half a year, about a third had emergencies, ending up in the emergency room, with 15% of families having multiple emergency room visits. And over half of the families had to use rescue medications, and many more had to use them multiple times. And as Tracy just mentioned, it's really not just seizures. And as we learned from our family advocates and an expert panel, it's associated with so much more, right? The profound disabilities that affect our day-to-day. The other thing is functional abilities, right? Mobility, ability to use spoken language, feeding that we've talked about, or going to the bathroom. And I love the discussion on poop because, full disclosure, I have 3-year-old twins, so we do a lot of poop. And then when you talk about seizure control, because I'm a neurosurgeon, right? So I guess I'm the, as my kids call it, the big bad wolf. But really, that's not the way we should think about it. We should think about kind of like, what is our toolbox? What is our armamentarium for dealing with these symptoms that we see and what we see as seizures, and how we can control the seizures? Can we help improve the outcomes? And everything else that we can measure, and also everything that we see and experience. So in summarizing some previous studies, we know that the developmental quotient in patients with Lennox-Gastaut syndrome, in a population that had actually received surgery, and those who were deemed appropriate candidates for resective surgery. So as you've navigated the epilepsy journey, with the imaging, with the EEGs, with trying to lateralize or localize where the seizures are coming from, certain patients are deemed candidates for resective surgery, so coming from only a part of the brain. And the patients who've actually had successful resective surgery, having some seizure control or having seizure freedom, or even having just some improvement, you'll see the developmental quotient actually got better or improved after surgery in the patients who were able to have some degree of seizure control. So that starts to kind of tell us if being able to control the seizures, or having even just a little bit fewer seizures, can have better outcomes in some way. So when resective surgery is not an appropriate option, what else do we know from other types of surgeries? So I'll mention a few, like vagus nerve stimulators, which is an implant that goes around the vagus nerve in the neck, and it almost looks like a little pacemaker with a little generator in the chest wall. And that gives signals to diffusely to the brain to, in my mind, it kind of tells the brain to calm down. We don't know who it's going to work in, but we think that in general it can help about half of the patients in a 50% kind of way. So it can, in the patients that it works in, it can have reduction in different seizure types, even though the FDA approval is very specific. But we've seen in LGS it can have seizure reduction across different seizure types, and have increased alertness in patients, and typically is generally safe without major complications. When you look at corpus callosotomy, that is different because that is a brain surgery, right? So it's actually cutting into the middle part of the brain, the white matter, and trying to disconnect the connection between the right side and the left side of the brain, so that seizures, when they start on one side, can't go across and generalize to the other side. So right to left and left to right and vice versa. So that typically is thought of as being very useful for drop attacks, and can have substantial seizure reduction, and is reported to have good cognitive improvements as well. So my team did a review of all of the studies done on this for LGS, and looking at medical versus surgical treatments. And then when we look at the published studies. And you'll see in blue, it's the medical therapies, and in green, it's the more common surgical therapies, which is VNS or corpus callosotomy. Understanding that there are other surgical treatments out there, like resective surgery, and now also deep brain stimulation and responsive neurostimulation are options that are being offered. So when you look at this, really we're looking at percent seizure reduction. So it's actually how low or how far down those colors go, because in the way this graph is set up, it's the lower and farther down it goes, it's actually more seizure reduction. So you can see actually like the blue and the green kind of reach about the same level. And that to us kind of tells us, well, we actually don't know if more medications or surgery is actually going to produce seizure reduction or have a good chance of producing seizure reduction. So that, we're calling equipoise, which really sets us up for a comparative effectiveness study saying, okay, well, we should really look at this, right? Is another medication going to give your child a better chance at seizure control, or is considering surgery going to give your child a better chance at seizure control? So here again, same QR code, inviting you to give feedback on a portion of the study. So I introduced the core team, and I think it's very important to the study team and to the PCORI team that we really look across multiple disciplines and get feedback from the LGS community. So it's not just me as a surgeon studying the one thing. So you heard about kind of the setup for the project. And then I'll kind of unpack the specific aims, but you'll see that there are a couple of them. There's aim 1A, aim 1B, and then aim 2. So we'll look at this. Aim 1A is actually looking at the impact of surgery or more medication on emergency department visits or intensive care unit admissions that are related to surgeries, right? So this is after a decision is made to continue medications or add medications versus a epilepsy surgery. After that, does that actually help decrease your chances and your frequency of going to the emergency room for seizures or actually be admitted to the hospital for that? The next is to actually look at the impact on outcomes that matter to you, right? So the first one I can say is probably outcomes that are easy to measure, right? Because I can find that in the medical record, we can find that in insurance, we can find that in national data, right? If there's an encounter for going to the hospital for seizures in the ER or the hospital. But really the outcomes that we've been talking about that I'm hearing is actually families, you are living every day on, is my child in pain, right? What is going on? How can we tell if our child is doing okay? And that's what we really need, engagement and your help in the community. How do we measure that? How do we even get to answering did this medication help? Did this surgery help? And I can tell you when I started training 20 years ago in surgery, that the way that we were taught to do research studies is, well, we did a study, we can do surgery and we didn't really bleed a lot. We didn't get an infection and people went home. So that went really well, right? But that's not reality, right? That's not what you care about, and that's not what I should care about in terms of a surgery going really well. Like we need to do better than that as doctors and as a healthcare community, because we should really be listening and understand what we do and what we can offer and how to really be good partners to help the quality of life of the entire community, and really think beyond, well, I did this surgery well, right? That doesn't mean anything to me anymore, right? I can tell you 20 years ago it really did, right? Because I really wanted to learn how to do the surgery, but it's so much more than that, and I have so much to learn from all of you. And really, so that's what AIM-1B is about, is to actually say, surveys, focus groups, and Tracy will help us work with families across the country for how do we really get at what this means and how we can do better and how we can give you the information for what is the next step in the epilepsy journey, how do we pick medicine versus surgery to be able to help your child and your family and your community. AIM-2 is actually how these therapies, medicine versus surgery, is being used for patients with LGS across the country. So this is really looking at real world, what is going on in the United States. And through that's looking at data and actually seeing, what is going on? How do patients actually get to an epileptologist? How do they get to a surgeon? Who is getting surgery? And are there challenges or barriers that are being set up by the healthcare system? And are there barriers in access to care that we really need to highlight and understand so that we can do better, so that we can take next steps? So the sites involved in AIM-1 are these listed here, and you've actually heard from multiple people at these sites and speakers from these sites: Colorado, Lurie Children's, Michigan, Nationwide, Pittsburgh, St. Louis, and Seattle. And then you'll see these other sites called light touch sites, which are the ones that we are collecting data from for AIM-2, which is giving us kind of a national look at all of the data. In the background, actually getting all of this data from PCORI and the PCORnet and all of the different hospitals needs a lot of data use agreements and a lot of kind of legalese that is happening. And that is actually how a lot of the data transfer is happening. And when we do that, those data are de-identified. So we will not be able to tell who that is. But part of some of the study will actually involve actually working with you guys directly. So for institutional review boards and ethics to make sure that the study protects everybody's privacy in healthcare data. We're working with our IRBs to make sure that we are keeping with guidelines and standards. So for AIM-1A, we've actually received approval. AIM-1B, actually working with families in surveys and focus groups, will be coming up towards the end of the year. And then AIM-2, working with de-identified data, will be later on. So actually the first part of the study is, before we could even use data to study LGS, we actually have to figure out if what's in the medical chart for somebody with the diagnosis of LGS actually has LGS. And that sounds weird, right? Because like the medical record should be like truth, right? But as we've talked about, even being eligible for certain medications, like CBD, you actually have to have a medical diagnosis of LGS. And then your insurance company would approve that. So we actually need to kind of look to see, how clean the data is, and actually look at each site if we can really make sense of the medical records to make sure what we think we're studying is actually what we're studying. So if you look at just in a medical record, or if you look at ICD-10 coding, the diagnosis codes for epilepsy actually can get like really messy. So these are like just a smattering of some epilepsy codes, and these are not LGS. Actually, LGS has its own code. But you can imagine that throughout the epilepsy journey, it could be conceivable that a patient with LGS or eventually diagnosed with LGS could have any of these codes in the medical record as well. So that's why we need to be really looking at this to see if we can capture all patients with LGS and to make sure the patients we say have LGS actually have it. So Mark Rosenman, one of my colleagues and co-investigators, is a medical informatics specialist. He's kind of helping us look at this problem to see how we actually identify patients with LGS in a medical record. And when you try to put together all of the kind of different Venn diagrams of who's on what medication, who had what diagnosis, and what is the likelihood of really having LGS in reality, this is what we're developing as a computable phenotype. So that's why AIM-1A, even before we can study the impact of medicines versus surgery on LGS, with the outcomes of coming to the ER or being admitted to the ICU with seizures, we actually have to do our homework and work with these high intensity sites to look in the medical records to make sure that we are really studying LGS. So, and then once we have those codes and the computable phenotype and know that we can identify LGS in the medical record, then we can actually look at real world utilization. So I can confess it would have been way easier if I just said, aha, there's an ICD-10 code for LGS. We're just gonna, write some computer program for this and analyze it and write a paper. But that's not good enough, right? Because it can be just garbage in, garbage out, right? And we really want to make sure that we are developing a way to study epilepsy and LGS in a way that is going to really carry forward, right? So this is really doing a lot of legwork for being able to study LGS in the future, and this hopefully is a building block. So same QR code for everybody to take a picture of and really start giving feedback. So I'm going to show the timeline of the study. So we're really going to be doing this over the next 3 years altogether. And so really it's just getting started. And really we're setting up our research team at the 7 high-intensity sites to start our IRB process and to make sure that we have somebody at every site that is committed to looking through charts to make sure that we know we're studying LGS. During the summer and then towards the end of the summer, we're really going to have develop stakeholder groups and focus groups to be able to look at your feedback and then look at really how are we going to best measure behavior, communication, and how do we really learn from LGS patients and families, and what is the best way to do that? And that will be happening through the latter half of the year. So really, we just started this study at the end of April of this year. So this is going to carry through for the next 3 years in the way that we laid out the AIM-1 and AIM-2. So really, my accountability to you is that I'm up here telling you this is what we're going to do, and that every year and much more frequently than that, we intend to really say, this is what we're doing. These are where we're hitting some bumps. This is where we need help. This is where we need to learn more so that we can really learn more together and keep on going. And my intention is that the timeline goes way beyond this because we will do more and more research together so that we can do better for all of you. So stay tuned. We'll give more and more updates. We're setting up our study website so that we can give more and more updates over time, and then really give formal reports in the upcoming conferences to come. So really where we want to go with this is just really building on this great LGS community to empower and support each other, and then really build a research community for epilepsy, for LGS, but for rare epilepsies and for epilepsy and beyond. And then really work with PCORI, a federal agency for for developing patient-centered outcomes research so that we can really study all together and to learn to use their database, which is a national database that has already been collecting data, but be able to inform them, hey, you're already doing all this work, you have data, but this is what works well, this is what doesn't work well, this is what we don't measure, and this is what we need to measure moving forward. So really to iterate and expand and work towards just a healthier future altogether. So thank you very much. This is really just the beginning, and we are looking forward to your feedback and just building together. So thank you, Tracy, for this opportunity, and thank you, everybody, for your time.
I have to say, I love this new world that we're entering with patients and researchers and doctors all working together and trying to find the solutions. I think it will save us time and money and agony. We have time for probably about 2 questions, but thank you so much. I'm excited about this study. I love that I'm listed as like one of the investigators when they're doing all the work. This is great. Can we do this all the time? I'm just kidding. But but I think it's going to be really great, and we're going to be bringing these opportunities to you as the patient community to answer surveys, to please take the QR code and answer that short survey to the best of your knowledge. If you don't remember, say, I don't know. But this type of stuff to really get the patient voice in there. So our first question right here.
Thank you. Thank you, Dr. Lam. This is really a great study. I did not know about this, and I'm definitely going to look up your recent article in 2021. What I've noticed in terms of when we're talking about sort of palliative is sort of the new term that we call for epilepsy surgery, and what I feel is missing in both resection and palliative discussions, because obviously before anybody, I don't know if anybody's been on the surgical pathway or has been admitted, there's something called a surgical conference that occurs, and it's where all of the epileptologists, neurosurgeons, and everybody meets and discusses your child's case. You're not invited, nor is there an ethicist, I think, and I really feel that there's a huge chunk of talking about quality of life presence. They do have social work attend, and we do have social workers, doing projects on QOL. But I think like nationally, it's hard to find that data. Because if you're talking about corpus callosotomy, for instance, it's very effective for drop seizures. But there's many candidates now seeking it who aren't ambulatory. So is there really a benefit in putting your child through surgery? I think it's like the hard questions that parents really want to get at aren't being asked in those sessions. So if a child's not ambulatory and they just nod their head, but nothing's, they're not falling on the ground and injuring themselves, do they really understand the risks of going through a surgery for that reason? So I just feel like the messages aren't clear for parents, and they're not being allowed to be in these discussions. It's really a meeting of, a great group of really smart people, but, are they thinking about the day-to-day? And that's what the parents think about,
Absolutely. No, that's things that we need to hear as a medical community, and really it's not we should be doing stuff to people, right? It's actually how are we going to make decisions all together that really matters to you, right? So, and I can tell you, from a surgeon's perspective, like super old school is, okay, can we do the surgery, and is it going to be like a home run, right? And epilepsy surgery used to be, okay, we're going to cure the seizures or we're not going to do it at all, right? And that's actually where the term palliative came in. It's actually, can we help reduce some of the seizures or the seizure burden, but it's not a cure, right? So that's actually kind of the root of the use of that term. But really, should we think about that in that way, right? Like, is it like a compromise or like not the best outcome? It's actually, it means a lot, right? But we need family and patient input for what matters the most, right? And what are meaningful outcomes, and what are things that are worth the kind of this looking at in the risk-benefit ratio. And that's why, you know, I really am just grateful for the opportunity to be able to look at this together and to learn together.
I would just add, too, that I was recently on a workshop for the Brain Initiative, which is run out of the White House Brain Initiative. And it was a neuroethics workshop, and about half of the members of the workshop were patients, on the ethics of putting devices in patients and doing it at the trial level, but then all the way out to the aftercare. And so I think those discussions, and I'm getting invited more and more to participate in these types of things where leadership at really high levels are trying to understand how best to implement that. But I think you make a great point where there's a lot of conversations that happen that we don't fully understand. Like, even if we were in that meeting, how much would we understand? Because I think one of the things I learned from this workshop was informed consent is really confusing, right? Like, not that I didn't already know that, but people don't really understand what they're informed consenting to, right? So I think that's a good point. Any other questions in the audience? All right, great. Well, let's give Dr. Lam a great big hand, and thank you so much. I'm looking forward to working with you.
Thank you.
Thank you.